at the end of the presentation. So if you have any questions and prefer to wait until the end, you're welcome to do that. And Dr. Cooley has agreed to share her presentation. If anyone is interested in that, you're welcome to put your email address in the chat bar, and I will record that and email it to you as soon as possible. Are there any questions? All right, let's get started. Dr. Cooley is our doctor from primary care and family medicine at Weeks Medical Center, which is an affiliate of North Country Healthcare. Dr. Cooley has been with Weeks Medical Center since 2020. Prior to her return in 2020, she was with the Groveton Clinic from 1997 to 2007 before moving to Peterborough, New Hampshire, and opening her own practice in cooperation with Monadnock Community Hospital. And until her return here again in 2020, we're so fortunate to have her with us again. In addition to her medical degree, Dr. Cooley also possesses a master's in public health, an MPH. In her practice, she's able to focus on health leadership, monitoring diseases, and managing outbreaks, and more for her patients as individuals, but also for our community at large. We thank you for participating, and let's go. Dr. Cooley, I'll turn it over to you.
Thanks. So thanks for asking for me to speak. A little background. So I got my MPH probably, I don't know, around 2019, 2018. And when I moved back to the North Country, I wanted to get involved with a public health project. So this project that I got involved with is through the New Hampshire Colorectal Screening Project, which is a grant-funded project that is spearheaded by Dr. Lynn Butterly, who was chief of GI, gastroenterology at Dartmouth for many years. And she's administering this grant for the CDC. And the point of the grant is to try to raise both awareness communities, but also awareness in providers of the importance of colorectal screening, colorectal cancer screening, and then also improve screening rates. And so it's about year 3 of a 5-year grant, and we work pretty closely together. I see Nikki's online, and she's a big part of my team here, which is kind of a busy team with lots of different people from different departments sort of working on different ways to help improve colorectal cancer screening for our patients at all the Weeks clinics. So I guess with that background, I'll kind of start. I guess a question that a lot of people still ask me as my patients is, why is colorectal cancer screening so important, and why does it make sense? And I just thought I'd throw up some slides of where Coos County is with regard to colorectal cancer and colorectal cancer screening, because I think if you understand, and I'm able to explain this to you, I think you'll understand why I think this is such an important topic. This is a map from a site from the CDC called the GIS, Geographical Information System, I think, which is a really fun interactive mapping system that you can just call up on your computer and then type in anything you're interested in terms of a health concern. And this particular map is obviously of the United States, and it's the colorectal cancer rates per state, and light blue or dark, if starting at the top, the dark blue color, if you see in the legend over here, is the healthy states with regard to colorectal cancer, and then the red are the unhealthier states. So the red states have the higher rates of colorectal cancer, and the bluer states have, and this has nothing to do with politics, but the bluer states are healthier in terms of colorectal cancer screening or colorectal cancer, not screening. And New Hampshire is pretty good. It's light blue state. Vermont's better. Massachusetts is better. California's better. But you can kind of get an idea all across the country, the different rates of and incidences of colorectal cancer. And this is New Hampshire and Coos County's rate of colorectal cancer when it's compared to other counties in New Hampshire, and we have a modestly elevated rate of colorectal cancer in Coos County as compared to other counties in the state. And there's a lot of reasons for this, and I won't get into it, but I just think it's interesting to kind of compare us when we compare other counties. I think more striking for me was that the rate of death from colorectal cancer is also mapped by the CDC. And in that respect, New Hampshire does pretty darn well. We have a lowish rate of colorectal cancer deaths in our state. And these states that had the higher incidences also have the higher incidences of death, and the red states. But when you look at Coos County, our rate of colorectal cancer deaths are higher in our county than they are mainly for most of the rest of the state. These numbers are hard to read, but what it read is 43.9 to 48 per 100,000 compared to 33.8 to 36.9. That doesn't sound like a lot, but it actually is. It's a modest difference, or a moderate difference. And more important to me, and this is kind of the take home, we'll come back to this at the end of the talk, the incidence rates for colorectal cancer late stage detection is much higher in Coos than it is in most of the other counties. So what this is basically telling us is that we catch it too late. Why we screen for colorectal cancer is because it's the number 2 most common cause of cancer deaths in the US compared to lung cancer only. And so if people didn't smoke, colorectal cancer would kill more Americans than any other cancer. I think people focus a lot on breast cancer, for example, when really colorectal cancer is a lot more deadly to Americans than breast cancer. I'm not saying that we shouldn't screen for breast cancer, but I just think it puts it in perspective. One of the great things about colorectal cancer, if there is a great thing, is that it's preventable. So if you screen and you catch polyps, and we'll get into this later, but if you catch a polyp at an early stage, a precancerous polyp that might have turned into cancer, and you snip that thing out of the colon, you save a person from having colorectal cancer. And there are very few cancers that we can actually prevent. So most cancers we try to screen for in their early stages, like breast cancer, et cetera. But colorectal cancer is actually preventable. When you compare to mammography, say you have a mammogram, you either have cancer or you don't. Okay, it's not a case of a precancer that's found. So in a lot of screenings we do, such as lung cancer screening with CAT scans, we find nodules that are, possibly precancerous, but generally they're early stages of cancer. And while the incidence of polyps on a colonoscopy is high, up to 40%, the actual frequency or the detection of a cancer in a colon on a colonoscopy is on the low side. So again, it speaks to this issue of if you do them if you screen at the appropriate times, you can actually prevent a cancer from developing. This is just a cartoon of kind of what polyps kind of look like on a colonoscopy. They get, they start off as little pimples basically and get bigger and bigger. And then cancer can start to develop what we call dysplasia, which is a precancerous condition, and then a cancer. And sometimes they tunnel this way. This is the outside of the colon. This is the inside of the colon. So that's kind of what they look like, more or less, to the endoscopist. Again, this is another cartoon, and the reason I showed this was to drive home a point that polyps often these are actually cancers, but you could say the same for polyps. They're actually big, but still don't occlude the colon lumen, the inside of the colon. And the reason I bring this up is because many patients over the years have declined colonoscopies when I've offered them, because they say they don't have any symptoms. And the problem with this is they won't have symptoms until they're totally occluded. And that's a major tumor or mass that's usually causing that degree of occlusion or closing off of the colon. There are a lot of different types of screening. I've highlighted the ones that most people are familiar with and the ones that we use the most often: fecal occult blood testing or fecal immunochemical testing, which is also known as FIT testing. And I'm going to go into each one of these dark blue tests in a second. Stool DNA testing, which is what most people know as Cologuard. Flexible sigmoidoscopy, used only for average risk patients. Many people don't even know what that is anymore. They are almost never done, but when I was starting in medicine, they were still used quite a bit. Air contrast barium enema, colonoscopy, virtual colonoscopy or colography, which is done with a special CAT scan, and then a pill cam, which can be done after a colonoscopy is completed but not adequate. And a pill cam is essentially they send a camera on in a pill down through the colon, and it takes pictures as it goes. Again, this is one that isn't used very often. So on the fecal occult blood testing, some take homes regarding these tests. There's a couple of them. One is the old guaiac based testing, and many people probably have seen those. That looks essentially just for hidden blood. The problem with the guaiac-based cards is that they detect blood, but it can be animal blood. And you used to have these things, and you would get it from the doctor or the provider, and you'd have to not eat red meat and not take your iron and all this. And so it was kind of hard for people to follow the instructions. The newer ones, called FIT tests, test only for human blood, and those are the ones that you'll see most often in offices today. What's good about it is it's easy to use. It can be done at home, and it's inexpensive. The guaiac-based test requires, like I said, some dietary and medication restrictions, and FIT testing does not. Anytime you have a positive card test or a FIT test or a guaiac test, you must have a colonoscopy. You can't repeat it and start over. It's positive once, it's positive, period. The problem a lot of people run into with the fecal occult blood testing is that in order for them to be helpful, you really have to do them on an annual basis. You can't skip a bunch of years, because what they're testing for is blood, and you might have a little tumor or a little polyp that's bleeding a little bit. And if you wait 3 years and do it again, you might not catch it the first time, but you might catch it 3 years down the line, but that's a more advanced pathology that you've got to worry about. So the part of the benefit of these tests is the fact that they're done every year. This is what they look like. There's three cards in a kit. You take it home from the doctor's office. You put 2 samples of your stool on 2 little windows after you flip the top open. It's 3 consecutive bowel movements, so it's essentially 6 stool tests. And the reason there are 3 is because you might miss it on the first 2. So it's these have been studied, and this is the number that's felt to be standard and appropriate to catch something. The likelihood of catching something is much higher with 3 tests. If your doctor, your provider does a rectal exam in the office and says, I just screened you for colon cancer, they really haven't. And there's a big misconception out there that a rectal exam in the office with one test, one of these, is good enough, and it's not. You really have to send the person home with the kit to do it the right way. This is another FIT test we don't use here. I know it's used in other offices, but basically you stick that little blue wand in a stool sample and then stick it cap it into a vial and send it away, and that is also an immunochemical test. Cologuard, I know, is advertised pretty heavily on television. We use them more and more at weeks. Our last data collection suggested that we had almost doubled the use of Cologuards in our offices, which I think is a good thing. It's a more sensitive test than the FIT cards. And the reason for that is it's checking for DNA on precancerous polyps. Its recommended use interval is 3 years, which is kind of nice for people. They don't have to be in the doctor's office 3 years, every single year to get these kits done, sent to them. The cost is higher, of course. It's a more technical test, but it's covered by most major insurers now in Medicare. And the nice piece, at least to the provider, is that they'll nag you if you don't do it. So they call that navigation. The people at the company will bother you until you send it back, and that's just to get a higher compliance rate. And every Cologuard test or kit also includes a FIT test. So they look like this, and this is the FIT, this is the sample box, and then this is what you send it back in. Colonoscopy is kind of what we call the gold standard, meaning it's really the only way to visualize the inside of the colon. And its goal really is to interrupt the polyp to cancer sequence. So the reason they're done is to get these polyps while they're young before they turn into cancers. The only prevention comes from a polypectomy. In other words, you can't prevent a cancer from developing unless you get rid of the polyp, the baby cancer or the polyp. This is what a colonoscope looks like. And this is a picture that Dr. Butterly shared with me. This is not her colon, it's somebody else's colon, but her name is on this. This was the polyp before, at the bottom, before it was snared. And that tool that you see, the white tool, has a little snare on the end of it, and it's opened up and it's fit over the top of the polyp, and then it's closed, and then the polyp is essentially singed off, and the top image is a picture of the colon once it was removed, or the polyp once it was it's a picture of the inside of the colon where the polyp was removed. This was a cancer actually that was found on a screening colonoscopy. And that was curative. He didn't need surgery or treatment or anything like that. That was the end. It was just the cancer was contained within the polyp and the margins were clear. So some of the language that we use for CRC testing includes the terms screening versus surveillance. Screening is for people who have never had screening or who have never had a positive finding on any screening. So every 10 years, if you have a colonoscopy and it's normal, in another 10 years, you'll have another screening. A surveillance is kind of like a menu in the sense that you find something in somebody that's not normal, but it's not cancer or is cancer. You develop a plan for surveilling that person from then on. It is not simply screening any longer, it's surveillance. And this is obviously for people with a personal history of polyps or cancer. We talk a lot in the language of colon cancer screening of average and increased risk. This is actually a very, I think, complicated and difficult thing for providers to remember and to understand. There's lots of reasons why people are increased risk, and there's lots of reasons why people aren't. But essentially, an average risk person is an asymptomatic individual age 45 or older with no personal or family history of colorectal cancer or polyps. So if your sister had a polyp, chances are it was adenomatous, and that type of polyp is considered precancerous, so that puts you at a higher risk of cancer, and you're then have to become surveilled and not just screened any longer. Increased risk people are people with any history of cancer, colorectal cancer, any people with a personal history of polyps, And there are generally two types of polyps, hyperplastic and adenomatous, but the ones that we talk about in medical charts are always the adenomatous ones. Those are the ones that we worry about. If you have a hyperplastic polyp on a colonoscopy, it's essentially not considered a pathology at all. And then there are those with family histories of colorectal cancer or polyps, and that gets a little tricky, not so much the colorectal cancer part, but the polyp part, because people sometimes don't know what their mother or their sister had, but we tend to assume they were adenomatous if they're under a surveillance plan. And then people with inflammatory bowel diseases, especially ulcerative colitis, are increased risk. And then there are other less known things like Lynch syndrome and other things like that, that I'm not going to get into tonight, but that those family histories put people at increased risk. So focusing on family history also helps us decide what type of test is best to use. The relationship of the affected relatives is important. First degree relatives, parents, siblings, and children lend higher risk. So the further out you go, great Aunt Millie doesn't count like your sister does. I have encountered people who were screened and had normal colonoscopies, but whose children are now in their 40s and they're getting screened and they have polyps. And we then turn around and tell the parent, you are now at increased risk and need more frequent surveillance. Ages of relatives at time of diagnosis is also critical to know. The younger the family member at the time of diagnosis, the greater risk to other family members. And I'll talk about that in a minute. And then the number of affected relatives, the more people, especially more first degree relatives that have been affected, the higher risk people are. And if you have a couple of first degree relatives and then a lot of aunts and uncles and grandparents, that's considered significant as well. So screening ages have changed recently. In 2018, the American Cancer Society recommended that the age to begin screening average risk people for colorectal cancer should be lowered from 50 to 45. And although the incidence of colorectal cancer in people over 50 is decreasing because we're getting better at surveilling them and screening them, the incidence of colorectal cancer for people under 50 is increasing. Annually in the US, there are approximately 15,000 cases of colorectal cancer in people under 50, and that death rate in that group is quite high. It's 3,600 deaths per 15,000. Now, the reason for this is probably because people who are younger aren't thinking they need to be screened, and colorectal cancer rates are increasing in younger people, and it probably starts in people's 20s and 30s, and then it comes to attention in their 40s. Data from the New Hampshire Colonoscopy Registry and other studies has shown that the frequency of polyps discovered on colonoscopies in 45 to 49-year-olds is actually very similar to that in patients 50 to 55. So this data supports what the ACS is saying, that we should be screening people younger than 50. So these are the current guidelines for average risk patients. You begin screening at age 45 with the FOBT that we talked about, the FIT test, and I almost never see this combination, so I'm putting it out there because it's a recommendation, but it's not practiced very often. A flexible sigmoidoscopy every 5 years or every 10 years if you do a FIT test every year. Well, I don't know. To me, that just seems like it's redundant, and the sigmoidoscopy only goes up part way up the colon, right? It doesn't go beyond the first turn of the colon. So the sigmoidoscopy is just the sigmoid colon. So it doesn't catch the rest of the colon. The next one is colonoscopy every 10 years if you have a normal colonoscopy, meaning if every 10 years you have a normal colonoscopy, you get a pass for 10 years. But if you have an abnormal one, then you are now in the above average risk category and have to go more often. The virtual colonoscopies can be done every 5 years. I've had a couple of patients who had to have those simply because they had such a difficult time with a colonoscopy. The only way we can image the colon is with the virtual colonoscopy, and those are done every 5 years because they're not as good a test. it's a CAT scan. They're just looking for shadows. So, it's not as good as a visualization from inside. And then the stool DNA test, the Cologuard that I mentioned, is done every 3 years. These are current screening guidelines. For patients at increased risk, the test of choice is colonoscopy. So even if you feel fine and whatever, if you have a relative, a mother or a sister or a dad, a child who's had problems, then you really need a colonoscopy to get the best bang for your buck in terms of screening or surveillance. And I think that this is a misunderstood concept. I see it in my patients that they think, as long as they're good about getting a FIT test, if their sister had colon cancer, they're fine, but really they need the colonoscopies done. Now, in patients with a family history of a first-degree relative with colon cancer, we begin screening at age 40, not 45, at age 40, or 10 years younger than the age that the relative first had their colon cancer detected. And an example is if your sister had colon cancer at 60, you begin screening at 40. And if your sister had colon cancer at 45, you begin at age 35. Other factors to consider in the prevention of CRC, besides catching polyps early, is diet. High fiber diets have been shown to lead to lower incidences of colon cancer in patients. And that means lots of fruits and vegetables, basically. Smoking is linked to colon cancer, and so don't smoke. Obesity and overweight is also linked to colon cancer. And exercise, it's been proven that regular aerobic cardiovascular exercise leads to less high incidence of colon cancer in cohorts that have been studied. What do I mean by exercise? Well, what I tell my patients is the current recommendations are 150 minutes a week of what I call break a sweat exercise. Yard work maybe, but gentle walking with a pokey dog really is an exercise. It's fun. It's good for you to be outdoors, but it's not what I call technically exercise. Exercise to me is brisk walking, hiking, bicycling, exercise classes, those types of things. Compelling cases for CRC screening. Again, it's preventable. The decrease in the incidence of CRC in older people over the last few decades shows that the screening is working. And yearly, the US spends $14 billion or more on colorectal cancer treatment. And obviously it saves lives. So back to this kind of unsettling map of Coos County and the high incidence rates of late detection in colon cancer. I would say that there are many reasons that the striking disparity in death rates from CRC in Coos County. One reason is that it stands out is that we don't screen often and early enough in our communities for CRC. And I think that's as much on the providers as it is on reluctant patients. Colorectal cancer is preventable, and the way it's prevented is from screening. Screening detects precancerous polyps and organizes patients into high-risk categories that would indicate that more frequent screening is necessary. So I'd like to leave you with that and help us help you be healthier and avoid this preventable form of cancer. If you believe you are due for CRC screening or you don't know and you have questions, please just call your healthcare provider's office today and they can help you sort out what you might need to do next.
Okay, I'm listening to Zoom now, girls.
So that's it. Anybody have any questions?
I do.
Yeah.
Okay. You answered one of my questions about having it done every 10 years.
Yep.
Now, I've been hearing some of my friends, because I'm older, and they're saying that after 80, they don't recommend having it done anymore. Is that true or not?
It's true.
I mean, if
for
they've been negative,
right, for the most part. So, and the reason for that is your risk of colonoscopy after 80 is higher than is considered safe. And if you were to say do a fit test and it were positive, say you were 83, then you would have to have a colonoscopy. So you get into these almost ethical dilemmas about, you know, what are you looking for? If your last colonoscopy was at 79, the chances of you developing a colon cancer that would lead to your death, quite honestly, is very low before your time, because your life expectancy as an American white woman is somewhere around 85 years. So that's the thinking, you know, that's the statistics of it.
Okay.
Yeah.
Okay. You mentioned if you had some family members that had colon cancer. My dad had pancreatic cancer. Does that apply?
Not necessarily.
Okay.
If there are certain cancer syndromes that put you at higher risk for cancer, period, but not necessarily colon cancer.
Okay. Okay, thank you.
Yeah, good questions.
I'm having one done Friday.
You can let us know how it goes.
Yeah. I've had one before, but it's you know, it's okay.
So Gail Sullivan joined us as well, and she's with the New Hampshire Colorectal Cancer Screening Project. And Nikki Smar works at Weeks and is involved with you know, the day-to-day workings of the surgical team, getting people in for, so if you have any questions, nuts and bolts questions for those two, I'm sure they'd be happy to answer too.
We have a couple of comments. Gail says, great job, Beth.
Okay, can I
Steve?
join in?
Steve to everyone says, thank you, Dr. Cooley. I've not met you in person yet, but you are my new PCP.
I hope you're up to date.
We'll check my records as I believe I maybe do.
Okay. So this talk will have saved me some time in the room with you to try to persuade you to do something.
Okay, can I join in?
Absolutely.
Okay, hello, my name is Rachel. I came on late. So
Uh-huh.
I don't know if you already spoke about this, but I have MS and I can't stand or walk. So I use a lift to go on the commode.
Yep.
And my last Cologuard was a positive. So I'm due to have a colonoscopy done, but I'm just feeling very apprehensive about the prep part.
Yep.
Being able to have enough energy to get on the commode each time. Do you have any recommendations?
Well, so there are a couple things. One is with the prep, and are you having it done at Weeks?
No, I'm having it done at AVH.
Okay.
I live in Berlin.
I think they use the same prep we use, but basically one of the good things about it is you start the day before with a clear liquid diet. So that gets rid of a lot of your stool right there. Okay.
Okay.
And then they do something called a split prep. So you don't do the giant jug all in one go. You split it between afternoon or evening and the next day.
Oh, really?
Yeah.
Oh, because I was given the big jug.
Yeah, so you should have instructions on how to use that. And if you want to talk to your team about the split prep, they can help you with that because it really helps. It cuts down on the time you're spending on the toilet, but it also it cuts down on the ghastly tummy ache you get, you know, from that stuff just sitting there. I tell people, this is probably not appropriate, but I tell them to sip it like a cocktail. Okay, don't try to chug it.
No, I've had this before, but yeah.
Yeah.
It's not a cocktail.
No, but you know what I'm saying? You don't want to try to, like, a lot of people sit down, they say, okay, I'm going to drink this glass of 8 ounces right now. And they like pour it all down their throat and it sits in your stomach and it's kind of heavy. So if you just keep slowly drinking at it and then spread it out over a bunch of hours, it seems to go better. At least that's what I think.
Suggestion. That's a good idea.
Yeah.
And I like the idea of splitting it in 2 days.
Yeah.
Good.
one of the things you can do is take the amount and put it in bottles and then ration the bottles and say, I have to
Yeah.
finish this bottle by this time. That's what I did, and it was very helpful.
Yeah.
Okay, thank you.
Any other questions?
You guys are quiet.
You did a good job explaining, that's why.
Oh,
Mhm, agreed. Well, is anyone interested in Dr. Cooley's materials? Her PowerPoint? All right.
good.
Thank you. Thank you.
Yes, thank you so much for joining us. We appreciate it. It was fabulous.
All right.
I don't
Take
know if you
care.
heard me, but I'm interested in your PowerPoints.
Okay.
Okay, thank you.
Yeah, we'll get to you. Take care.
All right.
Thank you. Thank you.
Bye.
Thanks, everybody. Good night.
Bye.
Night. Bye.